Late intraocular lenses dislocation is an uncommon complication after cataract surgery. However, the incidence is from 0.2% to 3%. In the near future, it may grow. A quick search on PubMed and we can observe it's already happening. This is due to the increasing life expectancy and highly improved phacoemulsification techniques. Late intraocular lens dislocation can be classified as simple decentration, subluxation of the intraocular lens, and intraocular lens and the bag complex dislocation. The last publication suggests 3 different management options depending on the severity of the lens dislocation. When carrying out the reposition of dislocated intraocular lenses, a 10.0 or a 9.0 polypropylene suture were first choices in various sclerofixation techniques. However, scientific studies have proven that 9 and 10.0 sutures have prone to cause a late breakdown in about 10 years. With that in mind, we began to think about a solution to that problem using 5.0 Prolene suture because it's 100 times more resistant and at least 10 times thicker than a 10.0 suture. 5.0 and 6 Prolene sutures are accessible and easier to handle. The suture is more resistant, sutureless techniques are faster, and the learning curve is flatter than other sclerofixation techniques. Other surgeons use Gore-Tex for intraocular lens sclerofixation, though its cost can be up to 20 times higher than a 5.0 or 6.0 Prolene offer. This is why a sutureless flange technique was chosen in 2 different cases we're about to show. Refixation of Morture Type 30B and Iridia intraocular lenses. Here we present a clinical case of a 36-year-old male who had a penetrating corneal injury with a traumatic cataract 12 years ago. At that moment, pars plana vitrectomy with lensectomy was performed. Later, an intraocular lens for an iridia correction Morture Type 30B was implanted and sutured to the sclera. After 11 years, the patient had a sudden and spontaneous visual loss of the operated eye. Intraocular lens dislocation with artificial lens complex to vitreous cavity was diagnosed. We have performed refixation of intraocular lens with artificial iris complex using 4-flange technique with 6.0 Prolene suture and 30-gauge needle. 6.0 Prolene suture was passed through the intraocular lens eyelets, and a suture loop was formed. Same steps were performed on the opposite side. The intraocular lens was centered, and the flanges outside the sclera were formed. The next day after the surgery, corneal edema and blood cells in the anterior chamber were observed. Despite the corneal scar 2 months later, uncorrected visual acuity was 20/30, and corrected visual acuity was 20/20 with a 1.25 diopter. In our knowledge, 4-flange sclerofixation technique has never been used before for refixation of dislocated intraocular lens with an artificial iris complex. Refixation of Fyodorov T26 intraocular lenses. In the second clinical case, we have a 76-year-old male patient who 30 years ago had extracapsular cataract extraction with Fyodorov T26 intraocular lens implantation. This IOL was designed with 2 haptics-like loops. Each haptic had 2 optic haptics junctions and was created for intracapsular implantation. These intraocular lenses were very popular in Eastern Europe in the 80s and the beginning of the 90s. After several tests, the best way we found to implement and to ensure steadiness and security was through the haptic holes in the IOL. As the diameter of this lens was 11 by 6 millimeters, it was implanted through the 5.5 millimeter incision, and it had a good adaptation to the size of the capsular bag, accurate centering, and low distributed pressure on the capsule. However, clinical practice shows that many of these intraocular lenses were implanted with 1 haptic in the capsular bag and 1 in ciliary sulcus. As for this patient, 1 intraocular lens haptic was in ciliary sulcus and another was in a capsular bag. 2 years ago, pars plana vitrectomy was performed because of the retinal detachment. Although when Richard's body was removed, patients soon presented with dislocated intraocular lens, and best-corrected distance visual acuity was 2200. The day after, the incorrected distance was 2080, and after a month, it reached 2025. This case perfectly illustrates how posterior chamber intraocular lenses with eyelets could be refixed using 4-flange technique. Challenges of the 4-flange technique. 4-flange technique has several advantages over other techniques for secondary intraocular implantation in the absence of capsular. It is less surgically traumatic for the eye, relatively simple, and is a quick procedure. It also provides a stable and secure fixation of the intraocular lens, with low risk of complications, such as suture erosion or dislocation. However, the tension of the suture adjusts the effective lens position and the intraocular lens tilt. It is hard to find the correct effective lens position in the surgery, and it may lead to refractive errors. Refractive surgery after scleral fixation may be a safe and effective way to correct residual refractive errors and improve patient visual outcomes. An intraoperative optical coherence tomography may help identify and correct it during surgery. More clinical experience and studies are required for minimizing intraocular lens tilt and postoperative refractive errors. Intraoperative optical coherence tomography usage and refractive surgery after scleral fixation should be the objectives of the future research to optimize 4-flange techniques for refixation or different dislocated intraocular lenses. Thank you.